He looked at me and said, rolled his eyes and says, "Thank God I don't have another." It was the B word for women, it was the N word for people of color, and it was the F word for LG. Decided to take my own stand there, and I turned around and walked out.
I'm Dr. David Spiro. Thanks for being here. I am incredibly delighted today to have, for the third time, I feel like this is David Letterman and Dan Aykroyd, because Dan Aykroyd was the first, one of the first guests, and he kept coming on. But I'm incredibly honored and delighted to have my colleague, Dr. David Shapiro. And yes, the Spiros and the Shapiros are now getting along. There was an issue. We won't get into that, but now it's good and in the past. And Dr. Shapiro is an incredibly talented and experienced surgeon. He's recently on a journey of procurement and transplantation medicine. He has been recently named the chair of the Stop the Bleed program, which is a very, very important initiative to improve the way that we care for folks in hemorrhagic shock. And really, he's a leader, not only locally, but on a national level in his area of trauma surgery and critical care medicine. We met when he was a fellow in critical care at Oregon Health and Science University. He has degrees from Harvard and hails from Connecticut now. And Dr. Shapiro, welcome back to the show.
Glad to be back here. I think my title in your thing is looking wrong, so I'm going to correct that. But One
It
Two I
won't
See
be.
You is my tag on.
Oh, it's okay. It gets ignored when we
Okay.
do
Well,
the
I'm
post
glad to be
edits.
back, and I appreciate you inviting me back.
Yeah, thanks for coming. What story did you want to share with us today?
Well, when we chatted, I thought about a few things that I think are important. And one of them that, I do a lot of advocacy work with violence prevention, injury prevention. I do the Stop the Bleed program. But one of the most important advocacy programs that I'm involved with is really human advocacy for the LGBT community. And most specifically, I do advocacy for LGBTQIA2S plus surgeons. I got involved in an organization a few years ago. Actually, I got involved before the organization existed with its founding chair or founding president. She was one of my residents, and she asked me, "Why is there no surgical organization for gay surgeons?" And I just looked at her and said, "I don't know. Maybe there aren't enough of us." So she looked into it. She inquired with me a few times. We chatted, and I've started a couple nonprofits in the past, and I've handed most of them off. I have a couple that I'm still involved with, but having started them, anyone who's out there who's done nonprofit work before knows that starting them is a pain in the butt. There's a lot of things to do, articles of incorporation and bylaws and all that stuff, and then the legal stuff that makes you do it. But then you have to get to the people that you need. And an organization or a nonprofit doesn't really exist without its number one, its constituents, people who are working in the program, and then who that nonprofit is benefiting. So her name is Nikki. I won't say her last name because I haven't gotten permission, but she was a surgical resident with me. She's now working in the field that I work in and is amazing and wonderful. And the organization we started was called the Association of Out Surgeons and Allies. And we have a website. It's called outsurgeons.org, and it's been around for, this is the 6th year, maybe it's the 7th year. This is the 7th year. We had a 5-year celebration 2 years ago. It's really grown to be several hundred people. We have several dozen sponsoring institutions, and these institutions have donated money, donated time, and donated support to make sure that people feel comfortable. But the real reason behind this goes to my story. When I was applying to residency, and this is when I was a 4th-year medical student in 2002, or yeah, 2000, no, 2001, I was applying. It was December that year, and I had gone to a variety of universities around the country and programs. And I remember going to one, and I will not mention the city it was in because that city is somewhere that I really enjoy, and I don't want to give it a bad reputation. But I went to the city with a friend of mine, one of my colleagues, classmates really. They and I went to the same program to interview on the same day and had very different experiences. We entered the room, and many of those physicians, medical students, and people who are in medical training will know that the process is you walk into your residency interview. Well, when it's in person, you walk in the door, you meet the coordinator, and then they sit you down, give you an intro, and then they give you your room assignments to go meet with interviewers. So I'd been given a room on the third floor. I walked up to the third floor and knocked on the door, and the door was ajar but not open all the way. And I looked inside and saw a perhaps mid to later career surgeon or person standing with his arms crossed facing the window. I knocked, and he just said, "Come." And I creaked open the door, felt very, very academic. And he looked me up and down after he turned around and used some very pejorative words. Now, this is 25 years ago, but this is after the year 2000. This is the 21st century. This is modern day. And he looked at me and said, rolled his eyes and says, "Thank God I don't have another pejorative for women, pejorative for a person of color, pejorative for a LGBT person to deal with right
Well, what do you want to share with me what the words were?
Um, I'd rather not, but,
Okay.
there were some bad ones, and let's
Okay.
just say it was the B word for women, it was the N word for people of color, and it was the F word for, LGBT folks. And I wasn't sure what
That's
to make of all.
horrible. By the way, that's just disgusting. It's
Agreed.
disgusting.
And it was a shock.
Was he an older guy?
He was probably in his 60s.
Mhm.
Um, uh, and I was a little in shock at first because as a person who's walking in the door for an interview, I'm in a suit, I'm wearing my bow tie, I'm feeling very
Mhm.
proper. And I was taken aback, and perhaps his methodology to put me at a point of unease was different than others, but completely ridiculous. I stood there for a moment or two, and he went on a short tirade of how programs are getting soft, and we really need strong male figures in surgery to make it through because that's what's going to bring us to the end and bring us to this solution. And then he made some comment about he's getting older and we'll need surgery someday, and he wants a man behind it. No, nobody else. I didn't know what to do, and I stood silent for about 30 seconds while he was on this tirade. And I
Mhm.
decided to take my own stand there, and I turned around and walked out. Um,
Wow. Wow.
I'm not usually well, I wasn't then usually that ballsy a person just to walk out of an interview, but I knew I was never going to want to go there. So I
Mhm.
left. I turned around, I walked down the stairs. I heard him say, "Hello?" And I just kept walking. I stopped into the coordinator's office and I said, "Listen, the experience I just had in the interview was horrifying, and I will not be coming here, so you can remove me from your list." She asked me, "Well, what happened?" I said, "I'd rather not talk about it." And I walked out and I stood outside the building near the on the way to the cars because that's where we told each other we would be waiting. And a few hours later, like, 3 hours later, they walked out and met me at the car, and we went to our car, and they said to me, how was your interview?" And I said, I didn't have one. I left. They told me that theirs was fine. They didn't meet with this person. I was appalled. I even spoke to my own advisor at my university at UConn and said, "What would you do?" And he said, "I would have done the same thing you did." The difference is, though, he didn't know I was gay. So while he supported me walking out, and I was in a situation I'd never been in before, it was very much an uneasy phenomenon to go through. And I realized that in the last, say, 25 years of residents going through that, if that happened then, it happened to other people. And
Mhm.
I wanted to make sure people felt comfortable coming to surgical programs. I started asking around. I was out to friends, but not all of them. I was present in the world. I participated in LGBT events, but the data shows that around 5% of United States surgical residents identify as LGBT. The range goes from 7 to 11%, maybe in others, but the they do report a similar career satisfaction. They are more likely to experience burnout, though, suicidal ideation, and have been experienced mistreatment far more than others. So my mistreatment in that program started the moment I interviewed. So I clearly didn't go there. I wound up at the University of Connecticut, and it was fine. I didn't have any problems with it. I wasn't a giant advocate during that time, but I found my experience not to be that unusual among classmates of mine and among other people that did residency applications and interviews in surgery. So I was determined to make sure that the difference would be that I would be participating in the difference instead of in the maintenance of the problem.
So do you think in 2026 that people who are LGBTQ, do you still feel that there is discrimination that's happening broadly in the States?
Well, yes, and if you mean among surgeons or do you mean among everybody? I think the answer is yes for both.
Hmm.
I think and I try not to be too political, but I think the current administration doesn't help that problem. It
Hmm.
empowers people to feel like they can say whatever they want, and they can say whatever they want because they have free speech to do so. But discrimination is different than prejudice. And I think that there's an opportunity, if you think about where we are in the world, we're facing a shortage of emergency medicine doctors, surgeons, primary care, and all different varieties of specialists. And as we go forward, I'm 52 years old. I'll be 53 in 3 weeks. I want to make sure that there are people there to take care of me. I want to be able to trust them. And quite
Hmm.
frankly, if there are not LGBT people in these specialties, I won't feel comfortable having treatments. So I want to make sure that one of the solutions for a shortage of surgeons is making sure we tap into the world that hasn't accessed surgery before because of either fear or trepidation or just wanton deliberate prejudice. Um,
Hmm.
Women are now about 50% of surgical trainees. The people of color in the business of surgery is still not what it should be. I witnessed um, frank prejudicial statements being shared on a community board, like on a chat room, so to speak, for one of the surgical organizations. And I think that being permitted is the frank racism that we talk about. So the fact that it's there for others means that we need to advocate for each other. We need to advocate for that kind of change and need to work on the comfort that people who are LGBTQIA2S plus have and their confidence in us as providers. It makes a difference.
So, what is it about the surgical profession? Because there'll be a lot of people who are learners or folks that are maybe not even in healthcare listening. What about the surgical profession, if you could describe, creates a little bit more of a hostile environment or a difficult environment for someone who happens to be gay or of color? What about surgery is different or not different compared to other because you actually in your world, and I said it in the introduction, you've had different lenses of different fields, maybe more than most people, because you've experienced ICU medicine, you've experienced anesthesia, you've experienced surgery, now you're doing procurement, um, ER. You have seen different lenses, but it feels like um, there's something about general surgery, trauma surgery, and it's changing. As you said, there are more women entering the field, but what is it about surgery that's made it difficult for people who are different and discrimination?
I wish I could say I didn't know because that would make me feel better as a human being. But I think that there's a nature of some intense specialties associated with the bravado and the hyper masculine surgeon, badass, arrogant experience that some people have, and there's certainly a depth to the specialty. There's certainly uh, um, and I'll dare say a bravado, a direct experience where surgeons are looked to as the captain of the ship in some ways. But that the evolution of that perspective has certainly changed over the years. And if we are to work as a system in medicine together, we have to do it the right way. But certainly there is a bravado, there is a competitive nature of surgical residency that I think is more from the 30 years ago version than it is modern day, but it still exists. I also think that there are correlations between specialties in surgery. For instance, people who go into orthopedics. We think of orthopedics as musclehead, crazies, but yet it's one of the most competitive specialties, not because they get to pound hammers, but because they're actually brilliantly smart. They restore physicality among people and give people the liberty of their lives. Every specialty has its life saving. Every specialty has its competitiveness, and every specialty has its needs and desires for wanting to be in that specialty. Emergency medicine is no different. It's just as, if not more, competitive these days. But I think that there is an old, um, adapted, and historical bravado that comes with surgery that people still stand by.
Mm.
And as I get the gray hair in my beard, I can feel it. I want to be one of the gray hairs that's inclusive and isn't afraid to say, no, you can do that. There's a lot of those stories that are out there, but really it's about the bravado that existed.
Do you think that in 2026 there are a number of trainees who are gay that are uncomfortable, uh, letting folks know they are or being open about it?
Absolutely, and I think that the most recent data we have is from a variety of papers published, and I published one of them. It's and I, full disclosure, I published a paper 3 years ago, I think in 2022, in the American Surgeon, called "The Role of the Scarecrow in Surgery," and I talk about the relationship that we have as surgeons with those people that are looking at our field. But certainly, people who are in surgical training are, dare I say, fearful. Some of them are confident. Some of them are completely comfortable. And it really depends on the environment they're in. I do have an acquaintance. I will not go into too many details about his history because it can be gleaned back to someone, but he was part of a program. He was in the actually not too far from where you are, Dr. Sparrow, and his experience was absolutely miserable because
Mm,
he was gay in a system and no one else was. But if you look at programs like the Association of Program Directors in Surgery, if you look at the American College of Surgeons, if you look at the American Board of Surgery, nothing in their realm of question asking or phenomenon of their application says, "Are you LGBT?" And I think that that is not a fault of the program. That is a very an HR thing to do. At the same time, imagine how much further it would be if we said, if you're LGBT, would you like to share that information? Because then we
mm,
could know more details. The only person, and I will say this, when I wrote that paper, I sent email, 5 emails to each of these leaders from every organization in professional surgical organizations around the world. Every one of them. I sent probably 140 emails 5 times each. I made about 400 phone calls. The one to respond was Patricia Turner from the American College of Surgeons, and she is now the president of the organization, or the executive CEO of the American College. And she's wonderful. She's thoughtful. But she didn't have an answer because they don't collect the information because people
mm,
are not willing to share it, and it may be a violation of privacy in some people's experience to ask that information.
mhm.
So it's hard to know. There are surveys. The surveys reach a few hundred people, and they don't really get there. I think 20, if I remember correctly, I'm looking at my data. Within the last 8 years is when the first time the matriculation survey for the ACGME included this information in their survey, and it was optional.
Yeah, you had talked also about the suicide rates and the burnout rates are higher amongst gay people, and who are surgeons. We just published a study here at Arkansas Children's Hospital about 3 or 4 months ago, so very recently published. And we were very curious if we gave teenagers who were suicidal an anonymous survey that wasn't tied back to the medical record, and they knew it was anonymous, and their parents didn't read the information on a tablet, and they filled out a validated survey around their sexuality and what percentage of the patients that came in with suicidality, so it's that population of teens, what percentage of children who were coming in who wanted to kill themselves were gay, and we found out that it was a third. And we hypothesized, based upon prevalence data in the general population, that it would have been 5%, maybe 10%, but it was at 33% of the children identified themselves as gay, and it was probably underreported. And so then the next question to ask is, what are we doing for children who come to the ED, who are struggling with depression and suicidality, especially in certain areas of the country, let's call it the South, where it's maybe uh, less accepted in some areas of society? And how do we um, address the underlying issue, which is how do we support you and how do we be inclusive? And I'm wondering with that data, which just came out, it's never been published. No one has ever studied this particular population. A, does it surprise you? And B, um, how can we better support people who are in their teens and in their 20s who then become trainees? How can we create a better environment so people feel included and accepted rather than rejected and excluded?
I'm glad because I know you also wrote a few other papers in the past. I read yours in pediatric emergency medicine, I think, about behavioral side of the same topic.
Mhm.
There's a few things to unpack there that are very, very important for both your listeners and their families. Number one, when someone feels free to share themselves, to share their personal and deep down feelings of who they are, that can be extremely liberating. It also can be extremely dangerous for them. And when someone knows that you're there to support them, whether it's behind closed doors and in secret, or it's out in public and being advocated for, it doesn't matter to me as long as the opportunity exists. I have spoken to a number of people in different environments are who have experienced the world of post-traumatic stress adjustment disorder, diagnosis related depression or situational depression, where they are LGBT in the army or in armed forces, or they're in a business that puts them at risk or at up to scrutiny when they admit that they're LGBT. And if you just look at the past, when we had, if you read some of the books about former spies and people in the CIA, if someone is gay, they are at risk because they can be fooled.
Leveraged.
They can be leveraged, and
Yeah.
especially if it's a secret. If it's out there, it can't be leveraged. I think that there's an opportunity for not for us to make demands of those young people who identify in a certain way, but to do what we have to do. And we have to be the ones that are open and welcoming. And I happen to have this sitting next to me, and these little pins that say, "You are safe with me." And it has rainbows on it. It doesn't need to have rainbows. I have one that I wear on my white coat and one that I wear on my vest when I give talks. That has the person of color, the Black Lives Matter, the "You are safe with me," and we're all together in healthcare. And the goal of this is to say to somebody, when you come to my program, to my office, to my examination table, I am here to make sure that you feel supported. If you have a question for me, I want you to ask it. And as
Mm.
someone who I was told I am mask presenting, I don't present as someone who people sometimes read in a certain way as being something, but I think that's all nonsense. It just has to be who you feel comfortable with. So if you are a program director in surgery, medicine, infectious disease, pediatric rheumatology, whatever you want to be in, if you're a program director, you need to make sure that you're sharing your pronouns. Why?
Mm.
Because it's a signal, it's a beacon, it's a moment in
Mhm.
time that someone says he shared his pronouns. Does that mean he's safe? Does that
Mm.
mean that she is okay? Someone doesn't have to be LGBTQIA2S plus to be accepting. Someone has to say that they're accepting and demonstrate that they're accepting to be accepting. Because there's a paucity of LGBT practitioners and clinicians out there, we can't just rely on those people to be the advocates when we go to the doctor. My doctor is not LGBT, and he's learned half of what he has to do from me because I've told him, you need to ask me about this, you need to ask your other patients about that. And I've given him this. And I will tell you, I have a package of about 400 of these that I buy every few months. I keep a handful in my pocket whenever I give a talk, whenever I'm somewhere and someone says, I like your pin. Here, take it. It's all yours as long as you wear it. And they almost always will wear it. I gave them out in my former hospital. I give them out in my practice now. I think it's important to just identify yourself as someone that is approachable, friendly, and acceptable. The other tidbit behind that is wearing a rainbow does not mean that you're LGBTQIA2S plus. And by the way, I use all the letters because everyone should be included in it. That doesn't mean that you are. It means that you accept, and it means that you more than tolerate. You support. You're an ally. And I don't have any preference on what you wear, what you do, what you say, but never make assumptions. Always make assumptions about yourself. Never assumptions about somebody else.
Mm,
Um, there's other stories I've experienced where a patient was on our colorectal service as a third year resident, and people referred to that patient as another pejorative
mm,
for someone who was trans. And back then, there wasn't really a word that was widely used for it, so people used different terms. But that person felt terrible during their hospitalization. Even the nursing staff were calling them a term that shouldn't be used.
mm.
So we have to be aware that these are our patients, these are our people, these are our communities, and some of them are actually our colleagues. And if you don't stand up and say something when something goes wrong, you're just as complicit.
Yeah, everyone deserves to be loved. Everyone deserves the opportunity to love and be loved however they want to be loved and however they want to give love. That's the way I think about it. And I'll share a brief anecdote from my own experience. I don't feel that I became aware. I feel like I developed a certain awareness of life in a more evolved state after I spent a few years in medical school in San Francisco. When I was in high school, my best friend in high school and I were together on a lot of different things. We were in drama and choir, and I was involved in a lot of different extracurriculars in high school. And at the end of high school, at graduation, he said that he loved me, and I said, "I love you too." And he said, "No, I love you." And I didn't handle it well, and I don't remember exactly what I did, but made me feel so uncomfortable in the moment. And we ended up and still have a lifelong relationship, but I don't think I handled it well in the moment. And when I went to San Francisco, I was there through the years 87 to 91 in medical school, and that was the height of the AIDS epidemic. And I got to experience the love and support of the AIDS community as they were dying in large numbers at San Francisco General Hospital, and the community and how they rallied. No one died alone. Let's put it that way. Or very few people died alone if you were gay in San Francisco. And I just developed an awareness of acceptance and a comfort. And it was part of my cultural upbringing, uh, probably, and the time I grew up in to not have any awareness, or I don't know what it is. And in some ways I feel ashamed to talk about the story, but it was a great learning opportunity. And I don't know where I was going with this, but I just thought I would share that story because I think that um, I get back to what I said to you before, that no matter what your color, religion, sexuality is, everyone deserves to be, in my opinion, everyone deserves to be loved and to give love the way they want to.
Thank you for sharing that with me. I think the the ability for us to generate our feelings and be able to express them to others when we're in our 50s, is different than when we were, in teenage years. And if you look at so I look at my niece and my nephew who are, both in high school now. And if you said, something about someone's sexuality or their gender identity or expression or their orientation, you'd be looked at like you were out of your mind, almost as if I said 6, 7 or something to them, because it's totally dorky to even discuss it because it's not an issue for them. The new generation does not have those prejudices. They don't have that experience. They also don't know who the Trevor Project is named for. They don't know about the AIDS epidemic. They don't know that experience. So I thank God. to a degree, or thank whatever deity you believe in to a degree. But you said something that's very, very important. The whether you have love in those experiences or not, being included at the table is what's important to me. And going back to the organization that we started, this AOSA, I don't think that there's a solution in creating diversity, equity, and inclusivity committees. The task force that effort needs to tell what other committees need to do. But the old adage that people give you is, it's not if you're not at the table, you're on the menu. Well, in my opinion, when you have an executive council and you give a seat to these organizations because their voice needs to be at every decision, that's how
Mhm.
to do it properly.
Mhm.
So when organizations hire a chief diversity or chief inclusivity officer, and they can have a voice at every step of the way, that's a better process than having a committee that's dedicated to looking at things that has little power or little influence. I think that's what's important to me. So, like no one dying alone, no one can make a decision alone. There has to be
Mhm.
a consideration for who's out there, who our patients are. I looked at a board I was on a few couple years ago at a hospital nearby, and the entire board, except for one person, was Caucasian, and the community in that city was 60% non-Caucasian. You can't do that. You have to
Mhm.
represent the people you're treating. You have to hear their voices and listen to their voices in real time. That's the only way to really accomplish it.
Well, it's really interesting because right now in Mexico, there's a female president that's Jewish, and we still see our House of Representatives has more diversity now than decades ago, but it feels like the Senate and the people who hold presidential office in this country still seem to be white men. And um, it's interesting. And the other interesting point is that it feels like, and again, I don't want to get political here, but it feels like diversity is a bad word right now. And I don't know. It's really, it's hard to see it because I felt like we were moving towards a more diversity and inclusion. It felt like we were moving towards a more evolved state. And if you look at Europe, and in all the different realms of European life, it's much more uh, evolved in that regard. And it feels like we were moving towards being evolved, and then it feels now it feels uncomfortable again. Am I? Is that a crazy statement? Does that?
It,
Uh,
yeah, it's not a crazy statement. I think but there's and I may get attacked for saying this, but there's a difference between demanding diversity and offering inclusivity. They're not opposites, but they're at opposite ends of the same table. When you demand diversity, people interpret that as saying we want to have a mix of different backgrounds and colors and genders and races and religions because we need it, or because we want it. Whereas inclusivity means that no one is left out. And those things can work together. There's a horrible image that I remember, and I use this in some talks about equity, where there are people standing behind a fence,
I
and
use the same image. I have the
and I
same image in one of my
hate it
slides.
because
Uh-huh.
the first image is everyone's on a box,
Yeah.
and you see
Yeah.
the tall person can see, the short person can't, and the little person can't. Then you see what reality is, and one person's on seven boxes, the other two are on nothing. But really, at the end of the day, all those people are still on the fence at the outfield and not sitting in the stands. So there's an inequity that we tolerate, which is something important to recognize. If you think about the way we treat the world now, we always have to identify differences instead of identifying how we're similar. We get to the table by demonstrating how we're different, or do we get to the table by demonstrating how we're similar? And then do we get the work done by demonstrating how we're similar and looking at how we're different? I think the work needs to be done. And for anyone who tries to eliminate a certain group from participating is doing that because of frank racism, uh, um, xenophobia, religious discrimination, homophobia, you name it. Those are the words that we use for that, and they're true because having been raised in a Jewish household and I'm LGBT, I stand on the stage and you wouldn't know it by looking at me what I am. I was at a meeting a couple weeks ago or a few weeks ago at the American College of Surgeons where one of the people on stage was a woman of color who's a chair of surgery. And she said, I can't hide my diversity. So why should anyone else? And I agree with that statement. We shouldn't have to hide anything, but I don't hide it by wearing my badge on my collar. Some people don't have that. And that means that I can hide, which I don't want to do. And that's because there are people out there who can't hide. And if you can't hide and you can't be passing as they use in the trans community or they used to use in the trans community, or you can't be straight acting, as they say in some LGBT worlds, you can't do it that way. You have to be inclusive of people's behaviors, their mannerisms, their languages, their terminology, their skin color, their everything, and that's what inclusivity is. Inclusivity is far more important um, in giving that seat at the table than anything. I want diversity everywhere. And I don't want it at the expense of inclusivity, and I don't want inclusivity at the expense of diversity.
Well, getting back to the story, I'm uh, I feel even more fortunate that you are a guest on the show, and I respect you even more because I think what you did in a position of where the interviewer has power and you're interviewing to get there, the that moment where you walked out of the office was a moment of courage, and I applaud you for that, and strength. And so when we get back to the Association of Out Surgeons, how do we, if someone wants to become involved in that organization, um, how do they
So,
do that?
two things. Number one, though I see that event in my interview as an act of fear and an act of wimping out, I can look back and say I was strong. I was this. What I want people to understand is that walking out is not you compromising anything. Staying is not you compromising anything. What if I stayed, interviewed, became part of that program, and then had the opportunity to change that man's mind?
Mm, mm.
Just keep that in mind. Courage, maybe. Um, Opportunity, yes. I was fearful, but don't be fearful. Second, I think the way to get people involved is if you and remember the AOSA is the Association of Out Surgeons and Allies. So we have members who are LGBTQIA2S plus. We have people who are self-identifying as straight, as cis, and we are working on getting some uh, cross-organization pollination with the folks from Pride Ortho and with other organizations that do support and defend the so-called um, forgotten groups, which I think is important. I will tell you that there are organizations called the Latino Surgical Society. There's the Association of Women Surgeons. There is the Society of Black Academic Surgeons, the Society of Asian Academic Surgeons, and there's a few others. We all work together to make sure that we all have a voice and a presence. So go to outsurgeons.org, look into membership if you want to. If you don't want to be a member, you don't have to, but you may want to sign up for a newsletter. You may want to get one of us to come speak at your university or your hospital because we all offer that, and we're willing to come and do a virtual or an in-person grand rounds. We can talk about these things. And the current president, his name is James Taylor. It's not the musician, but he's just as awesome, and he's really thinking about the next steps for the organization and seeing now. I think there have been four different presidents. I'm not one of them. I'm just an advisory chair. And seeing new people come through and be part of this organization and support the needs of LGBT medical students, residents, and surgeons is just incredible. I congratulate them.
Well, thank you for advocating. Thank you for being vulnerable and sharing a part of your story. And this episode is very meaningful to me on so many different levels. One of which is we get to spend some time together. And Now I know you in a completely different way, and I look forward to hearing more about Stop the Bleed in another episode and your work, which continues to span so many different realms of medicine, including advocacy. And you could have been a pediatrician, because we as pediatricians are advocates for children, but you're advocating for so many different other very, very important causes. And thank you for coming on the show today.
Thank you very much for having me, and I'm glad to come back anytime and listen to you and hear you interview because you bring out the best in people. Thank you.
Well, and it's also, again, I feel like that cow thing in Russia, the Spiros and Shapiros just need more love together, and we're making up for our right. We're just making up for our generations
Exactly.
of infighting between the Spiros and the Shapiros. Just to be clear, we still don't know what came first. Was it the Shapiro or the Spiro? We don't.
Would you like me to quote the Aramaic, doctor?
Please.
No, we're not going to do it. Next time.
Okay. For those of you listening to this episode, please hit subscribe and join the HUMED journey. We're now at this taping close to 55,000 subscribers on YouTube and growing. And I just want to continue the journey of sharing people like Dr. Shapiro and others who have stories to tell, to really unveil the essence of what is happening in healthcare. So be safe, and thank you again for joining. Hope everyone has a great day.
Thanks for listening to HUMED with David Spiro, MD. If you like this episode, make sure you're subscribed on Spotify, Apple, or your favorite podcast platform. The video versions are also available on YouTube. Make sure you subscribe and hit the bell there so that you never miss a future episode.